Така някъде да цъкне приеме, да му се изправя. Ще го дам отдолу. Точно ли го качи това нещо? Ги нямам.
Ема закачване тук, колеги. Тук от университета. Да. Окей. Къде е момичето? Ще дойде?
Само запомни на кой да е веден. Щом го знаеш.
So there is an announcement this lady wants to make. Go on.
Hello, everyone. I'm Dr. Francesca Goppini, and today is the International Day of the Woman. I just wanted to say, in memory of what happened in these days in Italy, that we are really, really lucky to be here today, because we wanted to be. It's not the same thing for every woman in the world, so it's a great thing, just this little thing. So have a good day, and bye.
So everybody's here. I think that we can start with the lectures. The first lecture will be presented by Professor Novakov. So it's about topographical anatomy of the hip joint. Topographical anatomy of the hip. Това ти да му кажеш ти кое е?
Хип, аз му казах кое е.
Хип.
Първа. Или втора.
Гърдъл и хип.
Пелви гърдъл и хип.
Да.
Ето това.
Да.
Окей.
Добро утро, buongiorno, good morning. We start with an anatomical workout this morning again. First two lectures on the topography of the lower limb. Bipedal locomotion is typical only for humans. There are some animals that run on 2 feet, but we are unique, we are different, and must stand upright. The design consideration are connected with stability in upright posture, ability to raise, control trunk over hind limbs, ability to balance on one leg, and walk with feet under the body. There was a famous roly-poly toy in the last century, 17th years, that was wibbles wobble, but they don't fall down. Lower legs are larger and heavier than upper extremities, so a comparison to that toy is possible. It's not the same with the egg. Egg can't stand on its less sharp end. Gluteal region. This is the surface markings of the gluteal region that you can see here. I'll be fast because we're late. Ligaments are the sacrotuberous, sacrospinous. Two openings which are formed between the bones and the ligaments are the greater and lesser sciatic foramen. Muscles are gluteus maximus, medius minimus, tensor fasciae lati, and the deep rotators like piriformis, obturator internus, the Gemini muscles, and the quadratus femoris. Vessels are the superior and inferior gluteal arteries, which are branches of the internal carotid. And the nerves include the biggest one in our body, sciatic, posterior cutaneous of the thigh, superior and inferior gluteal, nerves to the quadratus femoris muscle, to obturator, and internal pudendal. We start with the ligaments. Sacrotuberous and sacrospinous ligaments are shown. They surround the two openings, the greater and lesser sciatic foramen here. Biggest and powerful body muscles are those of the pelvic girdle. They arise from the pelvis and touch to the thigh and are organized into two main groups, anterior and posterior. The anterior group of muscle include psoas major, which is here. It originates from the bodies and the transverse processes of the first four lumbar vertebrae. The function is flexion and lateral rotation of the thigh together with the iliac muscle. The two under the inguinal ligament join to form the iliopsoas. The nerve supply is from the lumbar plexus for the psoas and the biggest of the branches, which is your femoral nerve. Posterior group are the gluteus muscles. Gluteus maximus, which originates from ilium, sacrum, and coccyx, inserts on the gluteal tuberosity and iliotibial tract that we can see here. The function is extension, lateral rotation, and abduction. Nerve supplied by the inferior gluteal nerve. This muscle, though bigger, it's lower too. The other two muscles, gluteus medius and minimus, they originate from the posterior aspect of the iliac bone, of the wing of the iliac bone, inserts on the trochanter major of the femur. The function is abduction and medial rotation, and nerve supplies from the superior gluteal nerve. These two muscles stabilize the pelvic girdle during walking. That's the gluteus maximus and its sacral attachment shown on this slide. The ability to balance on one leg also depends on the gluteal muscles, gluteus medius and minimus, which oppose the body weight, which is on that side. The Trendelenburg sign, which is shown here, also points the function of these two muscles. Positive sign shows weakness in this muscle, so the pelvis is tilting to one side. These muscles, like everything in our body, has variations. Variations are shown on this first slide here. The distal insertion of gluteus medius muscle fibers, which are shown in asterisk onto the tendon of gluteus minimus. And on the second one, we have these arrowheads pointing the attachment of the distal part of the gluteus medius to the piriformis muscle. The posterior group of muscle includes tensor fasciae latae also, which originates from the ACs, anterior superior iliac spine, inserts on the lateral condyle through the iliotibial tract, lateral condyle of tibia through the iliotibial tract, and the nerve supplies from the superior gluteal. In some books, it's classified as part of the gluteus muscles, like gluteus anterior one. So other muscles of the posterior group are the deep, small muscles, which are multiple, but they're mainly lateral rotators of the hip. Piriformis is a landmark there for the topography. Gemellus superior and inferior, which follows the obturator internus, and obturator externus, which is in front of the quadratus femoris. We can see these muscles on that picture. Here you can see the piriformis, which comes out through the greater sciatic foramen and encloses the supra and infrapiriform foramina here, where you can find the neurovascular bundles on the gluteal region. The three muscles that I mentioned are the tendon of the obturator internus and the two gemelli and the quadratus femoris muscle. Piriformis originates from the anterior surface of the sacrum, inserts on the greater trochanter. All these deep muscles are supplied by the muscular branches of the sacral plexus. And we already mentioned that the lateral rotates also hold the head of the femur in the acetabulum. Piriformis is also a variable muscle. A famous piriformis syndrome with a pain in the region of greater trochanter, gluteal region, and along the sciatic nerve also could be connected with some of the variations of the muscle. And of course, reasons are traumatic injury and scar formation in the area of the muscle. We already mentioned that this is a landmark muscle and big structures are surrounding this muscle. 6 types of relation between the sciatic nerve, the main nerve in that region, and the piriformis muscle. Bioton showed this, classified them in the last century, 37 years. So the first most often called as the standard one that we usually write down in the book, anatomical books for the students, is when an undivided nerve, sciatic nerve, goes under the inferior border of the muscle. The second most common, I'll show the percentage here. It's from Systematic Review of Nazis, a group of Greek colleagues here from the Athens University. So we have the common peroneal or common fibular nerve, which pierces the muscle, and the tibial portion comes under the piriformis. That's in the 8% of individuals. Common fibula above and tibial below the muscle in 2%. The whole of the sciatic nerve piercing the piriformis and dividing into 2 heads in 1% of individuals, and common fibula above and tibial through the muscle in less than 1%. And the same is the case when we have sciatic nerve coming above. So you have to be aware of these variations. The greater and lesser sciatic foramina are the two main openings here, which are formed between the bone and the ligaments. The greater sciatic foramen is formed between the greater sciatic notch of the hip bone and the two ligaments, sacrotuberous and sacrospinous ligament. Structures which you can find in that area, the piriformis, sciatic nerve, posterior cutaneous nerve of the thigh, superior and inferior gluteal neurovascular bundle, arteries and nerves, pudendal nerves, and of course the internal pudendal vessels. That's the greater sciatic foramen. And the structures with the piriformis muscle that further divides the foramen into supra and infrapiriform 1. The lesser is formed between the lesser sciatic notch of the ischial bone here and the sacrospinous and sacrotuberous ligaments. Structures that go transverse the foramen are the tendon of the obturator internus, which curves around here around the notch and reaches the trochanter. Nerve to obturator internus, pudendal nerve, and the pudendal vessels, internal pudendal vessels. That's the lesser sciatic foramen. Nerve supply of the area belongs to the two plexuses here, the lumbar and the sacral plexus, sometimes united as the lumbosacral plexus. Lumbar plexus arises from L1 to L4. It lies within the psoas muscle and is an anterior structure, while the sacral plexus L4 S4 lies caudal and is a posteriorly placed structure. That's schematic drawing of the plexus. The biggest nerve is the femoral one. Another drawing of the lumbar plexus, which show the nerves, femoral nerve, obturator. These two are mixed those nerves. They're both sensory and motor. Lateral femoral cutaneous, it's obviously sensory for that side of the thigh, lateral side. Genitofemoral is both. Superior and inferior gluteal nerves are motor. They supply the gluteal nerves, as we showed on the muscular presentation slides, and the posterior femoral cutaneous is sensory. Pudendal nerve is both. Other nerves to gluteal region includes those of the sacral plexus. Sciatic nerve is the branch of the plexus of L4, 5, and the first three sacral. Emerges to the pelvis through the lower part of the greater sciatic foramen. We saw its relation with the piriformis before. It's the largest nerve of the body, consists of tibial and common peroneal parts. Usually gives no branches in the gluteal region. Posterior cutaneous of the thigh enters the gluteal region through the lower part of the greater sciatic foramen below the piriformis muscle. Superior gluteal nerve, it's living through the suprapiriform foramen, which is here. That one, that's the sciatic, and internal and pudendal nerve also run through the infrapiriform foramen here. The nerve to quadratus femoris is for the muscle, the small muscular branch, and the pudendal that I already mentioned. Vessels and anastomosis around the pelvis and hip regions follow. The arteries of the pelvis are branches of internal iliac. Superior gluteal, the larger one of the two gluteal arteries, it's a short trunk-like branch of the posterior portion of the internal iliac. Exits the pelvis between the first sacral nerve and the lumbar sacral cord, and then branches into the superior portion of the upper part of gluteus maximus and the deep portion of the gluteus minimus of the buttocks. So that's the superior gluteal artery, that's the posterior trunk division of the internal iliac artery, and you can see how it goes in between the lumbosacral and the first sacral trunk there. Inferior gluteal, branch of the anterior trunk of these two trunks that were divided, and supplies the pelvic, gluteal, and posterior thigh structures, which already was mentioned with the muscles. Inferior gluteal is a continuation of the anterior trunk. The artery of the pelvis and thigh, I showed all the arteries here are shown as branches of the abdominal aorta, the common iliac, which divides into internal and external. External continues under the inguinal ligament, it's femoral. Deep femoral branches here with the medial and lateral circumflex femoral arteries. We are showing this slide to prepare you for the anastomosis around the hip. Femoral artery supplies the muscles of the anterior group of the pelvis and the muscles of the thigh. The two anastomoses are the trochanteric anastomosis. That's the main blood supply of the head of the femur. Arteries pass through the femoral neck beneath the capsule and includes the superior gluteal, inferior gluteal, and the two circumflex femoral arteries, the medial and lateral. The cruciate anastomosis is at the level of the lesser trochanter of the femur, together with the trochanteric anastomosis provides a connection between the internal and femoral arteries. And includes the inferior gluteal, superior is excluded in that anastomosis, the two circumflex medial and lateral, and the first perforating branch of the deep femoral artery. Here are the anastomosis, which we just listed. Trochanteric one, the two gluteal arteries, superior and inferior, ascending branches of the circumflex femoral, and then the other one is the cruciate, in which we add the ascending branch of the first perforating artery. Vascular supply of the head of the femur is commonly affected by vascular disorders. This is due partly to the interarticular position of this structure. The nature of the femoral head results in depending on retinacular blood supply. The supply is derived from anastomosis of larger vessels supplying the hip. These are the retinacular arteries here, and arterial supply from the obturator artery is shown also on that picture. Femoral head is vulnerable to avascular necrosis in the presence of femoral neck fracture, since these vessels are easily ruptured within its injury.
Thank you very much for this very interesting presentation. And we go on topographic anatomy of the knee and ankle, Sivkov.
Morning. I don't want to stay with my back towards you, so sorry for this first. So the knee, the knee complex, crucial region of our locomotor system. So it's the most vulnerable after the shoulder joint, especially in sports. Those like me, Professor Stout is quite aware of my knee. Those who have played soccer in their young years always have problems later with their knees. So the knee is a large complex. We have to discuss a lot of things here, not only the joint. It's between the two longest bones in the body, the femur and tibia, and this is one potential risk. Potential risk that occurs during torque of the lower limb. The fact that coupled with poor bone stability makes the knee very susceptible to injury. And it is so when you're not careful enough. The knee supports the weight of the body and transmits the forces to the ground. Forces that come from the whole body, the whole weight we have to bear. Functional stability is achieved by passive restraint of the ligaments. The ligaments are essential here. Active support of the muscles, powerful muscles around the joint. The geometry of the joint. This is, should know that this is a masterpiece of architecture. It's not human-made, and human cannot achieve such architecture, although replacement of our plastics is done. Anyway, the compressive forces also, pushing the bones together, also can be considered a factor of this stability. Anatomical characteristic. Patella, Although small and sesamoid bone that occurs within the tendon of one of the muscle, it's essential for the whole biomechanics of the region. Lateral and medial epicondyles are also structures that we have to consider when we present the region. The fibular head, known quite well, and also because one nerve passes just below this head, and it is often injured there, the common peroneal nerve. The content of the region that we have to discuss is first the skin, of course, then the subcutaneous layer where we have synovial bursae. Bursae are essential characteristic of any joint, and here we will see that there are, I think this is the joint with the greatest number of bursae, more than 20, here. Then comes the saphenous vein, great saphenous vein, saphenous nerve, knee fascia, and subfascial elements. Then the synovial bursae again, patellar ligament, retinaculum that keep patella along the axial line, and superficial pes anserinus, the goose foot. The skin is thick, hyperkerotic, moderately mobile. It becomes thinner in lateral direction. So it's not everywhere one and the same. So skin, hyperkerotic, moderately mobile. The subcutaneous layer is thin due to the absence of fat tissue here. Basically, you have skin, and after that we have the bursa with the patella. Great saphenous vein is here, and saphenous nerve medial to the knee, at a palm distance from the patellar margin. So it's how we can identify and find if you want to work on this surgically. So synovial bursa in the subcutaneous layer, the subcutaneous prepatellar bursa. Subcutaneous infrapatellar bursa in front of the patellar ligament, and subcutaneous bursa of the tibial tuberosity. You see the pavement worker. This subcutaneous prepatellar bursa is often inflamed, injured during the long-lasting stay on knee in this worker. So it's called pavement workers bursitis. This, when you see this bursa inflamed, redness, swelling, and pain occurring in this region. The deep fascia is continuation of fascia lata of the thigh, of course not of the femur, it should be the thigh. The subfascial elements should be the subfascial prepatellar bursa. It should be here, but a little bit hidden. Prepatellar bursa. Patellar ligament is attached to the tibial tuberosity here. And deep infrapatellar bursa is behind this. So on both sides of this patellar ligament we have bursa. You know bursa is essential where friction may occur. And here we have constant potential friction that can be between the tendon and the bone. The pes anserinus. Pes anserinus were the three tendons of three muscles you attach to the bone mutually. This is sartorius, gracilis, and semitendinous muscles. This pes anserinus is actually an attachment to the medial condyle of the tibia just behind the tibial tuberosity. So this is a place where maybe you, your colleagues, but also other plastic surgeons can take material for replacement of knee joint ligaments. Maybe you practice this today or later in your work. Bursa, beneath these ligaments we have a bursa, of course. We have three ligaments. It's not possible to attach without any protection against friction. So this bursa anserina is located next to the attachment. Bicep femoris is attached laterally on the other side, posteriorly. And the attachment is to the head of the fibula, iliotibial, tract-wise, superficially. One important bursa that should be mentioned here is this one. The biggest one that ascends behind the quadriceps, between the quadriceps and the femur. This is the most popular bursa among the students. And also it is widely used in traumatology to test whether we have some effusion inside, fluid inside the joint cavity, because it communicates freely with the joint cavity. If you need to make puncture, this is the place where we have to take sample of the fluid inside, on both sides of any side of the patella. You know this much better. So you see more than 20 bursae associated with the knee. I haven't seen all of them, of course. The most important are listed here. We mentioned them and showed them in the previous slides, but this is to summarize the importance of this, the number, and which are the most important, most often injured, inflamed, and causing problems. We can present both didactically and from biomechanical viewpoint the knee into compartments. The medial compartment is presented with the medial retinaculum that's close to the patella, pes anserinus, adductor magnus, one of the muscles of the thigh, the capsular ligaments, meniscofemoral, meniscotibial, and posterior oblique ligament. This structure is considered with stability of this medial compartment of the knee. Medial collateral ligament is also here, and posterior cruciate ligament. So we have always discussed this medial collateral ligament with one potentially risky structure that is most often damaged during sports because of its unfavorable position and location. You see the structures that we listed, starting from the retinaculum posteriorly and reaching the posterior compartment where is the posterior oblique ligament. The lateral compartment, we have the lateral retinaculum, iliotibial band is here. The biceps, attachment of the biceps to the head of the fibula, popliteus muscle, of course, it's essential in the lateral compartment with the lateral collateral ligament. These are closely related, and this is one of protections, one protection that ensures lateral collateral ligament to be less injured during sports and loading. Lateral capsular ligaments, meniscofemoral and meniscotibial ligament. Arcuate ligament is here, and anterior cruciate ligament. So the last row indicates what we have read in this compartment. You see the compartment here clearly presented, again starting from the retinaculum next to the patella and reaching the popliteal ligament posteriorly. Everything that you identify in this region is the lateral compartment of the knee. So posteriorly, it's a complex region. You should be very careful when you have to work there. I don't know what are your approaches to the knee. Anterior approach is usually easier than the posterior one because there are a lot of elements here. So first we have skin and fascia. Then we have the superficial popliteal fascia that contains fat, lesser saphenous vein, one cutaneous nerve, posterior femoral cutaneous nerve that descends from the thigh, saphenous nerve passing behind the medial corner of the femur, and one cutaneous nerve that will descend and supply the skin, posterior skin of the leg. Then we have posterior cutaneous femoral nerve that pierces this groove proximally, and lesser saphenous vein distally. Lesser saphenous vein pierces the fascia, popliteal fascia, and drains into the popliteal vein. So you'll see the end of this vein here, while the greater one will continue upward to drain in the region of the thigh there. So these are the superficial structures that you have to consider when you work here. I think that the most important are the veins. Well, the nerves are cutaneous and they will not cause severe damage of the structures, only certain numbness in the regions below. But veins should be considered. But the deep fascia, actually, is more dense, thick, and touchable. We can identify this. When we have extended knee, we can see that the tense fascia beneath, we can palpate the tense fascia beneath the fingers. It continues from the thigh, splits into two layers to accept the popliteal vein here, this one, and makes two septate to linea aspera. Linea aspera is on the posterior aspect. So, posterior aspect of the femur, and we can send two septae from this fascia for the muscles that we mentioned earlier, medial semitendinous and semimembranous, and lateral for the biceps. So two compartments for the muscles made by this deep fascia, and one compartment for the popliteal vein. The fossa is diamond-shaped. You have to know to outline the borders when you reach the fossa and start to dissect there. Above, medially, we have the semitendinous and semimembranous. Semimembranous is more expressed down because the other one is made present only with its tendon. Laterally is the biceps. The lower borders are the two heads of the gastrocnemius muscle, medial and lateral. On the floor, we have to identify above is the popliteal surface of the femur, bony structure. There should be placed the major elements of the neurovascular bundle. Then the new joint with its structure, capsule, upper tibia, oblique popliteal ligament, and popliteal muscle are here. Structures that we have to consider when you work there. The content of this fossa first is the tibial nerve more superficially. Along the midline, it bisects this diamond-shaped fossa. Then we have, may have or may not have part of the sciatic nerve. Normally this sciatic nerve bisects, splits into two here, but we can see it is split up in the thigh or in the gluteal region also. So sciatic nerve may also be present sometimes here. It supplies the posterior thigh and the leg, the nerve. Common peroneal nerve is laterally directed towards the biceps. It's also a branch of the sciatic nerve, no? And it branches into superficial and deep peroneal nerves around the neck of the fibula. This is the vulnerable place for this nerve. If there is an injury there, you know what occurs. This is the peroneal gate. Supplies the lateral and anterior leg, laterally superficial, anteriorly the deep peroneal nerve. And the sural nerve is on the back. It's superficially. It's made by branches given off by the two nerves that we mentioned above, common peroneal and tibial nerve. It's cutaneous. It's along the midline, running downward with the lesser saphenous vein towards the lateral malleolus of the ankle. So blood supply, we have in the region of the joints, you know that we have the so-called anastomosis, ensuring this by bypass in case of obstruction of the major vessel. These are quite essential, and we have always stress on this learning when we present anatomy to students. So this is essential here. You know, as mentioned in the previous lecture, here we have to see where the vessels come from the femoral artery, descending genicular, articular, and saphenous. Branches from popliteal artery, we have superior medial genicular, middle genicular, inferior middle genicular, superior lateral and inferior lateral genicular. So 2 paired, superior and inferior genicular, and one between them median non-paired, middle here. So from the tibia, we also have anterior and posterior tibial recurrent arteries. You see this recur backward here, anterior and posterior, anastomosing with the above mentioned artery. Pay attention that the lateral circumflex artery of the femur also sends descending branch here to join to this anastomosis, extensively presented anastomosis around the knee. So maybe you have this ability today to study this anastomosis if you are not quick enough to make the replacement of the joint. Genicular anastomosis, you see descending genicular from femoral artery, descending branch from lateral circumflex artery, genicular branch from the popliteal artery, medial and inferior paired genicular, lateral superior and inferior paired also. So you see, we see middle is added here, you see extensive here. This region is rich in paired and unpaired vessels. We identify them during our dissection, because we always make dissection with students, so these are easy to identify. This is from anterior tibial circumflex fibula, anterior tibial recurrent artery, and branches from posterior tibial. These are branches that will recur backward. These are from tibial artery. Posterior tibial recurrent. And this is now the innervation, in short here. Branches from the saphenous, obturator, tibial and common peroneal nerve. These are the nerves that will ensure nerve supply of the region. Cutaneous coverage of this region is completely covered with these branches. Saphenous is the longest branch of the femoral nerve that pierces here the vasa adductory lamina and descends to the great toe. So the coverage is entirely overlapping, is well presented here between the nerves. So numbness if you have damage of one nerve is not characteristic of this. Posteriorly, you have the coverage. This is the tibial or sciatic nerve. It depends on whether this split occurs. It is presented by posterior cutaneous nerve of the thigh, reaching the popliteal fossa. Sciatic and posterior femoral cutaneous nerve, and laterally we have common and fibular or peroneal nerve, where here it splits into two, passing beneath the head of the fibula. And the communications are essential always. You know that something may occur in a region that is not affected by the process. It is related with a region that is nearby. The popliteal fossa relates to the anterior femoral artery through the tendinous hiatus of the adductor canal. This is the place where the femoral nerve and vein will pass through and turn into popliteal. Posterior femoral region, with the posterior femoral region through the connective tissue around the sciatic nerve. The process, effusion, information can ascend through this fat tissue. And with the tibia around the connective tissue of the cruropopliteal canal that we mentioned before, in-sheathing the popliteal vein. These are pathways of spreading process. You should know them. You should think about this communication if you find a process somewhere, for example, in the thigh or in the leg, because this process may come from the knee region. And of course, the vice versa is also possible. That's what I wanted to tell you about the knee. Thank you. Thank you for listening.
We go on with the most useful approaches for hip arthroplasty. Dr. Golarov from Varna. Varna is on the Black Sea coast.
Ти как се ръкваш?
Тук за напред и тук.
Тук дясно?
Това за като го показва и отгоре. Ясно да напред.
Да.
Most useful surgical approaches to hip arthroplasty. The first approach is anterior approach or Smith-Peterson. Landmarks: the anterior superior iliac spine, the iliac crest. Incision: long incision following the anterior half of the iliac crest to the anterior superior iliac spine. Curve the incision down vertically for some 8 to 10 centimeters in medial part of the femur. Superficial surgical dissections. Externally rotate the leg to stretch the sartorius muscle. Identify the gap between the tensor fascia latae and the sartorius by palpation. Dissect down through the subcutaneous fat along the intermuscular interval. Avoid cutting the lateral femoral cutaneous nerve. Incise the deep fascia of the medial side of the tensor fascia latae. Deep surgical dissections. Retract the sartorius upward and medially, and the tensor fascia latae downward and laterally. Here is the blue arrow, it is the sartorius, and the black arrow, it is the tensor fascia latae. Then breaks you on the two muscles of the deep layer of the hip musculature. The retract femoris, femoral nerve, the gluteal medius. The capsule of joint, hip joint, is now exposed. Incise the hip joint capsule with a longitudinal or the T-shaped capsular incision. Dangers: the lateral femoral cutaneous nerve, vessels, the ascending branch of the lateral femoral cutaneous circumflex artery. Here is the femoral cutaneous nerve, and here is the circumflex femoral artery. Anterolateral approach or Watson-Jones approach. Landmarks: the anterior superior iliac spine, the great trochanter, the shaft of the femur. Incision: make the 15 centimeters straight longitudinal incision, centrate of the hip of the great trochanter. The incision crosses the posterior third of the trochanter and runs down to the shaft of the femur. Superficial surgical dissections. Incise the fat of the line of the skin. Incise the fascia lata entering the bursa and underlies it. Divide the fascia with scissors in the line of these fibers superiorly in the direction of the anterior superior iliac spine. Complete the fascial incision distally and slightly anteriorly to expose the underlying vastus lateralis muscle. Deep surgical dissections. Cut the insertions of the anterior portion of the gluteus medius just above its insertions into the great trochanter. Identify the thick white tendon of the gluteus minimus as insert into the anterior aspect of the trochanter and incise it. Detach the reflected head of the rectus femoris from the joint capsule to expose the anterior rim of the acetabulum. Place a Hoffman retract to the anterior rim of the acetabulum. Incise the anterior capsule of the hip joint with the H-shaped incision. Dangers. Nerves. The femoral nerve. Here. Vessels. The femoral artery and vein. The profunda femoris artery. All have protected by the Hoffman retractor of the anterior AC rim. Direct lateral approach or Harding approach. Landmark, the anterior superior iliac spine. The lateral aspect of great trochanter. The line of the femur. Skin incision begins 5 centimeters above the tip of the great trochanter. Longitudinal incision over the center of the tip of the great trochanter. Extends down the line of the shaft of the femur for 8 centimeters. Superficial surgical dissection. Incise the fat and underlying deep fascia in the line with the skin incision. Retract the fascia to pull the tensor fascia lati anteriorly of the gluteus medius posteriorly. Detach the fibers of the gluteus medius, then attach to the deep surface of this fascia by sharp dissections. The vastus lateralis and the gluteus medius are now exposed. Deep surgical dissection. Split the fibers of the gluteus medius muscles. Do not go more than 3 centimeters above the upper border of the trochanter. Proximal dissections may damage branches of the superior gluteal nerve. Split the fibers of the vastus lateralis, muscles over the lateral aspect of great trochanter. Developed at anterior flap. The anterior parts of gluteus medius muscles with gluteus minimus. The anterior part of the vastus lateralis muscles. The anterior hip joint capsule is full exposed. Detach the incision of the gluteus minimus tendon and the anterior part of the great trochanter. Enter the capsule using the longitudinal T-shaped incision. Dangers. First, the nerve, femoral nerve. Vessels, the femoral artery and vein, the profunda femoris artery, here with yellow arrows, all have protected by the Hoffman retractor and the anterior AC rim. Posterior approach, more approach. Landmark. Palpate the great trochanter of the other aspect of teeth. Incision. Make the 10 to 15 centimeter covers incision centrate of the posterior aspect of great trochanter. Begin your incision some 6 to 8 centimeters above the posterior aspect of the great trochanter. The part of incision that runs from this point to the posterior aspect of the trochanter is in line with the fibers of the gluteus maximus. Curve the incision across the buttock, cutting over the posterior aspect of the trochanter and continue down along the shaft of the femur. Incision. If you flex the hip 90 degrees and make the straight longitudinal incision over the posterior aspect of the trochanter, it will curve into the Moore style incision when the limb is straight. The final incision is curved to 10 to 15 centimeters long, centrate of the posterior aspect of great trochanter. Superficial surgical dissection. Incise the fascia lata of the lateral aspect of the femur. Lay the fascial incision superiorly in line with the skin incision. Split the fibers of the gluteus maximus by both dissections. Split the muscle gently for maybe able to pick up, coagulate, and cut the crossing vessels. Deep surgical dissections. Retract the gluteus maximus and the deep fascia of the teeth. Underneath the posterior aspect of the hip joint, covered by the short external rotator muscles attached to the upper part of the posterolateral aspect of the femur. The sciatic nerve leaves the pelvis through the great sciatic notch and runs down, escape the fatty tissue, crosses the obturator internus to the two gemini and the quadratus femoris before disappearing beneath the femoral attachment of the gluteus maximus. Find the nerve line of the short external rotators. Palpation. Do not dissect to see the nerve. Internally rotate the hip to put the short external rotators muscles on the stretch, making them more prominent. Put the operative field farther from the sciatic nerve. Insert stay sutures into the piriforms and the obturator internus tendons just before they insert into the great trochanter. Detach the muscles close to their femoral insertions and reflect them backward, lying from them over the sciatic nerve to protect it during the rest of the procedure. The posterior aspect of hip joint capsule is now fully exposed. Incise the joint capsule with a longitudinal or T-shaped incision. Dislocation of the hip by internal rotation after capsulotomy. Now posterior joint capsulotomy will be exposed the femoral hand and neck. Dangers. Nerves. The sciatic nerve. If can be damaged if it is compressed by the posterior blade of the retractor used to split the quadratus gluteus maximus. Always keep the retractors of the cut surface of the rotators. The muscles will protect the nerve. The sciatic nerve something divides into the tibial and the common peroneal branches with the pelvis. You may expose these two sciatic nerves during these approaches. If you identified the sciatic nerve but it look too small, search for the nerve's others branch. It is the danger, it is the overlooked. Dangers. Vessels, the inferior gluteus artery, beneath the piriforms. Identify and coagulate its branches when the gluteus maximus is split. The main trunk of the artery. If it retracts into the pelvis and bleeding, turn the patient over into the supine position, open the abdomen to the artery, filled vessels, the internal iliac artery. Mini-invasive surgery. The first approach is anterolateral Röttinger, the name of Heinz Röttinger approach. Approach to the hip by the intermuscular interval anterior to the abductors, posterior of the tensor fasciae lati. Preserving abductor muscles attachment intact. Incision. Locate the anterior superior iliac spine. Incision of the anterior tubercle of the great trochanter 7 to 9 centimeters toward the iliac spine. The first 2 centimeters of the incision lies over the trochanter. The superior gluteus nerve lies protected to the incision and protected from damage by the gluteus muscles. Superficial surgical dissections. Subcutaneous fat at incised and retracted in line with the skin incision. Palpate the intermuscular interval between the tensor fasciae latae and the gluteus muscles, minimus and medius. The first incision in the fascia lata is made close to the great trochanter, beginning at the femoral insertion site. Expose the small fat pad which the acts of the glide to the intermuscular interval. Deep surgical dissections. Both dissections of the muscles is made down to the joint capsule. The gluteal muscles are retracted with the first common retractor placed inferior to the femoral neck and overlying of the joint capsule. Anterior approach. Incision lateral to the glide line between spinal iliac anterior superior and the head of the femur. Superficial surgical dissection. Incision of the tensor fascia latae. Deep surgical dissections. Both dissections of the intermuscular space, positioning the retractors. Take care not to damage nervus cutaneus femoris lateralis. Deep surgical dissections. Ligate the bundle of the circumflex vessels. Exposure of the femoral neck for osteotomy. For implantation of the prosthesis, you need special instruments. Posterior mini-invasive approach. Skin incision 1.5 times larger from the diameters of the femoral head. Superficial surgical dissections. Bone retractor to skin and subcutaneous fat. Hoffman retractor between the musculus piriformis and the muscle gluteus medius to the upper part of the femoral neck. Hoffman retractor between musculus quadratus femoris and musculus obturatorius externus to the lower part of the femoral neck. Deep surgical dissection. Capsulotomy exposing the femoral head. The pelvic trochanteric muscles are between the retractor and the sciatic nerve to protect it. The external rotators are damaged. Thank you for your attention.
Okay. Next speaker, Professor Stavrev, knee surgery approach.
Okay, it's a little bit more to go, and then we'll have coffee break. So I'll be short enough. So after the hip joint, we go to the knee surgical approaches. So this is the knee anatomy. Professor Sivkov already spoke about the knee anatomy. So on the left, we have the front view. Most of all know it. And here is the side view. The ligaments, we go straight to the approaches. These are the cruciate ligaments. You can see the anterior, the posterior cruciate ligament, the lateral and the medial collateral ligaments. Regarding the approaches, we must bear in mind that the medial collateral ligament is usually healed to the medial meniscus, so when we do the approach for total knee replacement surgery, we must protect the lateral and the medial collateral ligaments, because if we cut one of these ligaments, it will be a big issue regarding the surgery. We cannot place a standard prosthesis, but if we have iatrogenically cut one, either the medial or the lateral collateral ligament, we must replace the standard prosthesis with a hinge prosthesis. Otherwise, the knee will be totally unstable. So this is the posterior view. We can see the posterior cruciate ligament. Again, we can see the medial and the lateral collateral ligaments. And this is a view from above. We can see the meniscuses, the kneecap, ligamentum patellae proprium, and here is the tendon of the quadriceps muscle. Usually the lateral meniscus is much smaller, and the medial one is bigger, but I think you know that the medial meniscus is 9 times more commonly injured than the lateral one. So the other thing is that all intra-articular injuries of the knee are treated arthroscopically, especially in young patients like you. We mustn't leave big scars. We must do everything endoscopically. So, axis of the lower limb, this is very important when we do a total knee replacement. This is the standard weight-bearing axis. So, regarding the thing that this is an axis, it takes 3 points. The first point, this is the center of the rotation, the middle of the femoral head. The second point, this is the middle of the knee. And the third point, this is the middle of the ankle joint. So whenever we do a total knee replacement surgery, we must restore this axis. The biomechanical axis of loading of the lower extremity. If we do not do so, the prosthesis will fail. So there are many instruments. It is very fashionable nowadays to use navigation, but the main point is to restore the axis, to restore the full range of motion, and to make a stable knee joint. If we do this, our surgery will be successful. So, muscles around the knee, Professor Sivkov already exposed, pes anserinus, gastrocnemius, and so on and so on. We will not lose time. This is the lateral view. And these are the pathologic conditions. On the left here, we see the restored weight-bearing axis of the knee joint. And here we can see valgus knee. And here is the varus knee. So regarding our experience, the varus knee deformities are much more common than the valgus knee deformities. So knee prosthesis is a very common surgery, but in our country, the knee prosthesis are less common than the hip prosthesis. Anyway, the implantation of this prosthesis is because of gonarthrosis, of degenerative disease of the knee joint. So this here is a standard knee prosthesis. So one of the most common approaches for exposing the knee joist, this is the von Langenbeck approach, the medial parapatellar approach. So the skin incision can be either straight or medial parapatellar. I prefer the straight incision because the scar is much better, especially if you do a cosmetic intradermal suturing of the skin. Anyway, this is only the skin incision, but when we go deep, this is the deeper incision, we must incise the medial parapatellar retinaculum. So when we incise the medial parapatellar retinaculum, we usually retract laterally the patella. And when we do so, we expose very well the knee joint. We can see the cruciate ligaments. We must preserve ligamentum patellae proprium. And we go on with the surgery. Regarding the modern prosthesis, in Bulgaria, we prefer to use a posterior stabilized knee prosthesis. This means that in the course of the surgery, we cut both the anterior and the posterior cruciate ligaments in order to stabilize the knee joint, but we must preserve the medial collateral ligament and the lateral collateral ligament, because I told you, if we cut one of these ligaments, this is a big issue. We must go for different type of prosthesis. So, more fashionable lately is the subvastus approach to the knee, because the extensor mechanism of the knee is better preserved. This is very similar to the Langenbeck approach, but we must split the fibers of the vastus medialis muscle. So this is better when we do so. I usually do so. The patient complain less because the extensor mechanism of the knee is better preserved. So this is how we do it. Again, after this approach, we can see the cruciate ligaments. We go on, we excise them, and we continue with the implantation of the prosthesis. So there is also anterolateral approach to the knee if we want to go laterally. So this is the skin incision and this is the deep dissection. If we wish to work on the lateral side, when we go deeper, we can see the structures that are deeper. The lateral femoral condyle, the kneecap, the head of the fibula, the lateral collateral ligament. So this is how we do it if we wish to work on the lateral side of the knee. The problem is that when we use this approach, we cannot invert the patella medially. We only have to retract it. Direct posterior approach to the knee. So this is the less commonly used approach because, you know, we have to enter fossa popliteal. All the big vessels are inside. So we have to be very careful because if we cut the popliteal artery, we must bear in mind that this artery does not have any anastomosis. So there will be no blood supply from the knee joint distally. If we do so, we must go for a vascular surgeon to restore the popliteal artery. Otherwise, the final result will be amputation. So these are the nerves, the tibial nerve, the common peroneal nerve. After this deep dissection. And here we can see the popliteal artery with the branches that curve around the knee and go anteriorly. We can see the gastrocnemius muscles and so on. So medial approach to the knee, the Hoppenfeld and the Boer approach. So in the past, this approach has been used for meniscectomy, but I told you in the beginning of my talk that all the meniscal lesions now are treated endoscopically. We mustn't leave such big scar, especially if the patient is a lady, because she cannot wear a short skirt. The scar will be well visible. That's why if there is a problem with the medial or the lateral meniscus, everything is done endoscopically. This is after the deep dissection. The only thing that is dangerous when we do this dissection is the infrapatellar branch of the saphenous nerve. It is a sensory nerve, but if possible, we must preserve it. If it is not possible, we can cut it because this is not a motor nerve. When we go deeper, we can see the medial parapatellar retinaculum and the other remaining structures. Lateral approach to the knee. the main landmark, this is the Gerdi tubercle. It is a curved incision. This approach is recommended by the AO group. It is sometimes we use it when we wish to implant a distal femoral plate, minimally invasively, interlocking plate. So after we do the exposure, we see the inlaying structures. You can see the patella and the other things. The thing that is dangerous, this is the common peroneal nerve, which is here, very close to the head of the fibula. If heterogenically we damage the common peroneal nerve, this is a big issue because there will be no dorsiflexion of the foot. There will be a foot drop. So we must bear in mind that we are very close to the common peroneal nerve, and when we do our cuts, we must stay away from this nerve. This was a video, but it doesn't work. Total knee replacement. I think it is better to go to the next one, which is more interesting. So yesterday, Professor Makoro presented a very interesting case. Most of you are very sleepy. Now I want to present another very interesting case of ours, which I believe we did for the first time in Bulgaria. This was a 3D printed individual tumor endoprosthesis, which we did on a 4-year-old child, a small young gypsy boy, which had who had a big tumor. You'll see we miss all the empty talks. So regarding the tumor prosthesis, there are 3 generations. Here on this slide, you can see the first generation of growing prosthesis. This is a child, so the prosthesis must grow, must get longer. So the first generation, on certain periods, we have to make surgeries and place rings. First with the small ring, then higher rings, and in this way, like a car antenna, the prosthesis is becoming longer. But we must do many surgeries to elongate the prosthesis. This is the first generation. The second generation of prosthesis, they are elongated in a different manner. You can see when we rotate these bolts, this makes elongation of the femoral part and the tibial part. So we can reach these parts with small incisions, and when we rotate the bolts, the prosthesis is becoming longer. So in the third generation, these are the magnetically controlled prostheses. There is a special mechanism, and when we see that there is a leg-leg discrepancy, we call our patient to come in the hospital. There is a magnetic device, and like a car antenna, when we use this magnetic device, the prosthesis is becoming longer. So in our case, this is the child, a very big tumor, engaging 3/4 of the tibia. As you see, a small boy, gypsy boy, 4 years old. This was a Ewing sarcoma. The Ewing sarcoma is a very malignant tumor. And here it was already a biopsy site. In another hospital, they have made a biopsy, and the pathologist, they have diagnosed a Ewing sarcoma. Luckily, there were no metastases in the lungs or anywhere else. The other thing was in another hospital, they proposed an above-the-knee amputation, but the father, the old gypsy, rejected because the lower extremity of the father was amputated due to injury. So they said, the parents said, oh, the father of this boy is with amputated leg, we do not allow you to amputate the leg of our child. So we thought a lot and we decided to do a 3D printing and produce an individual dual growing prosthesis. So this was the first model. This is the 3D printing. And this is what we were offered by the engineers of the company. They proposed growing only on the tibial side of the prosthesis. But because this is a hinge mechanism, we had to cut the distal femoral physis. And from anatomy, you must know that the distal femoral physis is responsible for 75% of the growth of the femur. So we didn't like this first model, and we said, you must do extension mechanism not only on the tibial side, but also on the femoral side. These are the locking bolts. This is porous coating for osseointegration. So this was, the yellow is the primary model, and the blue is the model that we requested with growing on the femoral side and growing on the tibial side. This is how engineerily the prosthesis looks. It will grow on the femoral side, it will grow on the tibial side as well. So this will be a double growing prosthesis. So this is a picture taken in the operating theater. We covered the prosthesis with a textile tube. It is called Lars tube, in order to reinsert the muscles to the prosthesis. We had to cut 3/3 of the tibia, so we had to reinsert ligamentum patellae to the prosthesis, and we also had to reinforce with the medial head of the gastrocnemius muscle to strengthen the extensor mechanisms of the knee joint. So this is intraoperative X-ray. This is the distal locking. So it was done in 2 planes, from anterior to posterior with 2 bolts, with 2 screws, and from medial to lateral with another 2 screws. As you see, we have preserved the distal tibial physis. So here, the growing of the tibia is preserved. Only in the proximal part, we had to remove the proximal tibial physis. So this is an intraoperative video. I will show you. This is the distal femur, you can see. It is exposed, the distal femur, it will be cut. We invited a vascular surgeon. We were using a medial approach. So when you do such big operation, you must see the vessels and you must protect them. After the distal femur is exposed, we had to resect it. So here you can see the prosthesis is already implanted. You can see the textile tube that covers the tibia. And these are the final X-rays. You see this is a big implant. It is locked with 2 screws in the proximal femoral fragment, and it is locked with 4 screws on the distal part of the tibia. So the growing in the femur is from this mechanism, and the growing of the tibia is from this mechanism. Why we didn't use magnetically controlled? The bad issue for the magnetically controlled prosthesis is that they can grow for maximum of 4 centimeters. And when we did our calculations, we estimated that we need 8 centimeters from the femur and another 8 centimeters from the tibia. So it makes 16 centimeters. That's why we used this 2nd generation prosthesis. Now it is already 8 months after the surgery, and in the middle of December, the child will come, will do small incisions, and will elongate the prosthesis. So this is once again the prosthesis. And this is the child. This is 6 months after surgery. No, 5, I think.
Hadi.
So you can notice that there is no hair. This is from the chemotherapy. I told you that the Ewing sarcoma is a very bad tumor. So actually, this small boy was referred by the pediatrician to us.
Benden yaşlı.
As you see, they are Bulgarian citizens, but they are talking in Gypsy language. I think this is the same in Italy. You cannot change the genome. Here we will
Haydi küçük
demonstrate
versinik.
the extensor mechanism. So when we finished,
Haydi pimpata.
we gave 1.5 centimeters length more. We make, you see the
Hayır,
left
otur şimdi sağ ayaklarını
extremity,
aşağı.
1.5
Hayır hayır, beri
centimeters
otur da sağ
longer
ayaklarını aşağı.
to save
Sağ aşağı ayaklarını ikisini.
one
Oynattır
surgery.
ayaklarını aşağı yukarı.
So the right one is the prosthetic. So we have some extension.
Oynat. Öbürünü de ikisini de yavaş yavaş. Davayı kaldır.
Yavaş
indir.
yavaş
Kaldır
means
indir.
slowly. Kaldır means elevate.
Bravo. Haydi küçük versinik.
Kaç kere?
So as a conclusion, our purpose was to do a total revision by the end of the growth of the skeleton and to substitute this prosthesis with a permanent one, which is a non-growing prosthesis. But this will happen if there are no pulmonary or other metastases. The future expectations the non-invasive mechanisms, magnetically controlled, etc., and the biological access will prevail. But up to now, this is what we managed to do, and I think this is an acceptable solution for this small child, because the parents didn't accept any amputation, and up to now, I think that we managed to save the lower extremity. Thank you.
And last presentation of this section, ankle foot surgical approach. Dr. Vitiello.
Hi all. So we start our talking with the approach to the foot and ankle. We start with the ankle approach, then the calcaneal approach, and in the last part, the foot approach to the talus and the least front joints. The first approach is the anterior ankle approach. This is the real anterior approach that born to provide a good visualization of the total ankle joints. So the distal part of the tibia, the medial malleolus, and then the talar bone. The incision is a vertical incision that starts on the cresta of the tibia and then go down on the axis of the second metatarsal bone. In the superficial dissection, we have to take care about the branch of the superficial peroneal nerve that have a big inter-individual variability, so take care and is very, very superficial. Then we go between the extensor digitorum longus and extensor hallucis longus and take care that behind the extensor digitorum longus there is the neurovascular bundle. So this is the deep dissection. We go between the two tendons and there is the fascia and then the subtalar and then the ankle joints. Here you can see the arches. So here there is the extensor digitorum, here the extensor hallucis longus. This is the neurovascular bundle, and here there is the visualization. You can see all the ankle joints. This is an approach that was born for the ankle fusion or the ankle arthrodesis or the ankle arthroplasty. Then we have the anteromedial approach that provides a good visualization of the medial malleolus and medial distal part of the tibia. The starting of the incision is the same of the anterior, but in the distal part we have to curve toward the anterior tibialis tendon. There isn't a very important neurovascular bundle structure in these arches, but we have to take care of the anterior tibialis sheath, because if there is a damaging during the surgery of the anterior tibialis sheath in the post-surgery period, there could be the bow effect, and this is a very important risk factor for the wound healing. Here you can see the deep dissection, the distal part of the tibia, medial malleolus, and talar bone. We can also go on the foot to see also the talonavicular joints on the upper part. The other approach is the anterolateral approach. The start of the incision is the same, but in the distal part we have to follow the axis of the foremetatarsal base. In the superficial and in the upper part of the incision there is the superficial peroneal nerve, and in the deep dissection we have to take off the anterior compartment muscle on the medial side, and this is the exposure, so the distal tibia, the talar dome, and here you can see the fibula, and this is a very useful approach for the syndesmosis. So if we have a Chapeau-Thilot fracture, we can use this approach to see better this part of the distal tibia. Then we have the medial approach to the ankle. This approach was born for the monomalleolar fracture to have an anatomical reduction of the malleolus. We start the incision on the tip of the medial malleus and go on the axis in the upper part of the tibia. There is also an extension in the distal part of the medial approach to see better the talonavicular joints and the first cuneiform, and so we can curve our incision in distal part following the tibialis posterior tendon. This approach is also useful for the amnipoplate for a pilon fracture. In the superficial dissection, we have the saphenous vein and the saphenous nerve in the more proximal part of the incision, and we have to take care of the posterior tibialis tendon sheath in the posterior part of the flap. This is the exposure with the malleolus. Then we have the lateral approach for the fibula. In surgery room, you can take a little tip that you have to take the tip of the fibula. You have to, with a finger, take the head of the fibula, take a line centimeters, and draw a line. This is the axis of the fibula, that is the same axis of the arches. You can put your arches about 10-15 centimeters. In the distal part, we have to avoid the lesion with the superficial peroneal nerve, and in the posterior part, there is the sural nerve and the saphenous vein. In the deep dissection, we have to take care of the muscle. The real approach is between the peroneus tertius and peroneus longus and peroneus brevis, and this is the surgical exposure of all the fibula. In the distal part, with a subperiosteal way, we can go here to see also the syndesmosis. So, but we have to take care to the superficial peroneal nerve. So we have always to go with a subperiosteal way. Then there is the posterior approach to the ankle. There is two big families, that is the posterolateral approach and the posteromedial approach. The posterolateral approach is an incision that goes between the Achilles tendon and the distal part of the fibula, and in the distal part of the incision goes slightly curved alongside the tibialis, the Achilles tendon. We have to avoid the lesion with the sural nerve. From cadaveric study, we know that the sural nerve crosses the incision about 5 centimeters up to the tip of the fibula. So take care about this, and you have to know that it's really, really superficial, the sural nerve. So in the first time, we have to search it and to take care of it. In the deeper part, we have different windows. There is the first window between the flexor hallucis longus and the peroneal tendon to go to the Volkmann fragment, to the fracture of the third malleolus. Here you can see the arches. We go to the Folkman fragment, and we can plate also the fibula from a posterior way. Take care about the peroneal tendon, because in the deeper part of the peroneal tendon there is the peroneal artery and vein. With this posterolateral approach, we can also go laterally to the peroneal tendon to plate the fibula with a lateral plate from a posterior lateral approach. So is a surgeon choice. This is the approach, the incision, femur, flexor hallucis longus, this is the fibula, and this is the Folkman fragment. Then there is the posteromedial approach, more uncommon. The incision start from the distal part of the tibia and go alongside with the tibialis posterior tendon. In the superficial layer there is not very important structure, but in the deeper layer there is the neurovascular bundle. We have the neurovascular bundle go behind the flexor digitorum longus, and in the deeper dissection we have different windows to approach different parts of the distal tibia. So if we have a more important fracture of the medial malleolus, we can go between the malleolus and tibialis posterior tendon, or we can go between tibialis posterior and the flexor digitorum longus to approach a more medial fracture like a Folkman fragment, or if we have a bigger part with the medial side, we have to go between the neurovascular bundle and flexor hallucis longus. So we have different windows to different approach. This is the incision, flexor hallucis longus, this is the neurovascular bundle, and this is the posterior tibia. About the calcaneus approach, the medial approach is an approach that was born for the substentaculum tali fracture. We have to center our incision on the substentaculum tali. We have to touch the substentaculum tali. You have to remember that in the upper part of the substentaculum tali there is the posterior tibialis tendon, and in the inferior part under the substentaculum talis go the flexor longus hallucis. So we can move the hallux, feel where is the tendon, and so centered our incision on the substentaculum tali. More or less is 2 centimeters under the tip of the medial malleolus and 2 centimeters from the navicular bone. So this is the deep dissection. So in the upper part of the flap we have the neurovascular bundle with the posterior tibialis tendon, and in the inferior part we have the flexor hallucis longus, and here there is the substentaculum tali. So if we have a fracture, this is our approach. The lateral approach, the most useful approach, is the Seligson approach, that is an evolution of the Cocker approach. This is an L-shaped approach with the posterior arm incision that go between the Achilles tendon and posterior part of the fibula, more near Achilles tendon, because there is the sural nerve in the proximal part. We go down, and then the arm with the horizontal arm is parallel to the 5th metatarsal. It's very important to take one full thickness flap, because there are 3 important structures: the sural nerve, the peroneal tendon, and also there is a lateral branch of the calcanear that is very important for the vascularization of the calcaneus. So with one flap we can take care of all these fracture, all these structure here. In the deeper dissection there is the retinaculum of the peroneal tendon that we have to cut it to move the tendon, and there is the fibulocalcaneal ligament that we have to sacrifice to enter in the subtalar joint. Here there is all the calcaneus, the flap, and this is the subtalar joint. But for the subtalar joint there is another approach that is a sinus tarsi approach that is more useful. Here the approach starts from the tip of the fibula and go down on the axis of the 4th metatarsal bone. Here there is the dissection. To see here we have to detach the peroneus brevis tendon muscle that start from the calcaneal surface, and then this is the subtalar joint. This is a very useful approach for the mini-invasive plate for the calcaneus fracture, or for the coalition of the subtalar joint, or for the subtalar arthrodesis. Then we can also continue our approach in the proximal part behind the fibula if there is a dislocation of the peroneal tendon. That is a quite common complication of calcaneal fracture. Then we have the anteromedial and anterolateral approach for the talus, more uncommon, but this is a aviator fracture. We have the anteromedial approach is the natural evolution of the medial approach to the ankle, but the distal part of the incision go very longitudinally. We have not a curve that following the tibialis posterior tendon, as I have already said. This is the superficial dissection. In the upper part I have the saphenous vein and the saphenous nerve, and then after the incision of the fascia we are on the talar neck. So talar neck, here the fracture, this is the head of the talus and the talonavicular joints. In most of the cases, in the fracture of the talus, we need both approach, the anteromedial and anterolateral, to manage the fracture. The anterolateral approach is the natural evolution of the anterolateral approach of the ankle. So we follow the fourth metatarsal base of the metatarsal. We have to take care of the superficial peroneal nerve. This is the incision of the fascia. Here there is the joint capsule. There is the anterior inferior tibiofibular ligament. And in the distal part, beyond this sinus tarsi fat pad, there is the talar dome, the neck, and the head of the talus. In the distal part, we have also an approach to the talonavicular joint in the upper part. Lastly, we have the Lisfranc complex joint approach, that is the dorsomedial and dorsolateral approach. The dorsomedial approach starts in the middle of the navicular bone and follow the axis of the first medial cuneiform and the first ray. So we go between the tibialis anterior tendon and the extensor hallucis longus tendon. In the deeper part, we have two windows. The first window is between these two tendons, and we can see the navicular bone, the medial cuneiform, and the base of the first metatarsal bone. Then we have another window, the lateral part, so we go laterally to the extensor hallucis longus, and we have to take care in the lateral part of the incision because there is the neurovascular bundle, and this second window allow us to see better the medial cuneiform and the base of the second, and the real Lisfranc articular surface here. The dorsolateral approach for the Lisfranc complex is more uncommon and is a straight incision on the cuboid bone. We have to take care in the distal part a branch of the sural nerve, and we have to avoid a very near incision. When we have to perform the both approach, anteromedial and dorsomedial and dorsolateral approach, we have to keep a minimum of 5 centimeters between the incision to avoid the risk of skin necrosis after the surgery. So take care of this. And in the deep dissection, take care of the sural nerve. In particular, if you have to go distally to see better the base of the metatarsal bone. This approach was born for the calcaneo-cuboidal joints, but if we go distally, we can see also the fifth metatarsal bone and the fourth and the third. Thank you.
Now, coffee break.
down is this one.
In the second half, forward.
Okay.
You are?
Thank God. If you want, I can write it. FNGA, this one. Surgical.
Okay.
I'll check just the video. Just a second.
Yes, please.
The presentation. Okay. Okay. Perfect. Okay. Thank you. Per forza. Perfect. Thank you.
Sorry, can I post my presentation? Yes, of course. Here you go. You are? The last one. The last one. Yep, Baltimore. Тимонов. Да. Благодаря. Можеш? Аз не знам какво става. Да, то свикнахме вече. Професор Старо, като започне да цигаси да говори, викам, колко много езици има вече. Официално. С полиглота. Копирайте я само, която е в Second Half папката, за да не се объркаме, че да, предпочитам така. Мисля, че сме тук вече.
It's a folder. This is okay. You have to take all three. Okay, because there are two.
Професор Силко, как сте?
One movie and a sound movie. This is in second half.
The second half. After the coffee break.
Yes,
That's why-
yes.
And you are? I'm sorry. Let me see. Simoncini?
No, Brunetto.
Brunetto, third one. Okay.
Okay.
The presentation and two images.
Yes.
You want to show them separately from the presentation.
No, they are inside.
They are in the presentation.
May you try to to open it.
Yes, of course.
Okay. Pronto.
Do you have any videos on it?
Sì.
Живота аз малко.
Mi dia 2 minuti e la vediamo.
Okay, we tested, it's okay. Do you have any videos on it?
Sì. Ok.
Photos, yes. Which right? Do you know exactly?
Perfect. And the next one. Next one. May we reduce the volume?
There is no volume here.
No, a small volume is necessary. We have to listen.
Господин Монов.
Ще
just
до PDF, че не знам дали ще може ли да може презентационно.
PDF.
PDF, да. Аз го трябваше ще го позове. Ами, да имам и OTP, ама не така. Едното това е Open Document. Да, не знам. Ще отвори. Не съм сигурен това как ще отвори, защото е писано на LibreOffice. Вероятно ще има грешка. Не. Я пробвах един. Не. Така, аз съм подвинал, там неща са доста парламентарни. Ели ще има там.
Има Excel.
Не, защото нали презентационен режим, нали ще имаме другия екран. Онлайн. Free trial, бла бла бла. Знаеш как се презентира?
То се презентира обикновеното, даже и поинтера ще работи. После как се даваш на цял екран. Това ми се не вижда тези лентичките. Знаеш, имаше някъде. Аз съм много скоро имах за с PDF, някой беше бутна PDF. Да, знаеш как. Значи 5 дупликейт и излиза и там. И после си го върнем пак за презентация на екстент.
OBS ще го ходи?
Той фаща екрана на лаптопа OBS.
Да, фаща.
И виж, пак с това. Я не гледате ли ще там? За да си ясен, да, ще малко по-си търпелив.
Аз не съм най-важен.
Ай сега. Всеки, който изнася е важен. Да, екстенди го. A kako pravite?
Evo, tuka ili na polskom?
Znači imaš gospodina psihijatrata i postoji u tvojoj portfoliju.
Da.
PDF. Ti si номер 12.
Gde smo da? Ima ti živjeti.
Ti si
Dear colleagues, dear participants, we begin our second session this morning. The first topic is Back to Newton, Hip and Knee Biomechanics, presented by Simoncini.
So, good morning to anyone, to all of you. We are going to talk today about a topic which is maybe not often covered in academic courses, and we've got 15 minutes, more or less, to talk about something that maybe would deserve a whole academic course by itself. Anyway, we are going to talk about not how it is, not how to do. We're going to talk about how it works. And we're talking mainly about joints. And especially sometimes the clinical experience, the clinical studies struggle trying to isolate the effects of single causes. You have a cause because you don't have a single cause usually. You have a lot of causes, a lot of effects that interact and shade a curtain of fog in the interpretation of data. Anyway, Mr. Isaac Newton discovered a set of laws that we always have to obey. So they could be a light in the interpretation and even in the behavior, in the procedure that we do in the OR each day. So my first question is going to be a very easy one. Could an apple fall upwards? Can he? No, of course no. Even though I try 1,000 of times, of course, no, this bloody apple will always fall downwards. So we can start from here, okay? This is something we know for sure. An apple will fall downwards. But wait, what's happening here? What do you think is happening there? The wind is, yeah, or try to, he's flying. Yeah, in a way he's flying. Maybe it's a fake. This picture is a fake, maybe. Or there are invisible wires hanging. But I don't think that anyone would say the gravity is not working anymore. No one thought about that. So let me use the words of one who knows about force. The whole human body must obey to the law of forces. Does it work? Yeah, it does. And you know what? Joints and skeleton and muscles are all about forces. So knowing how it works allows us to make it work again after surgery. Look at him, is our friend Isaac again. And is making you a very important question. What do you really do when you make a surgery? And especially I'm thinking to prosthetic surgery. What do you think? What do you think we are doing when you do a surgery? Whoever. Whoever has an answer. Think that the question is made by Mr. Isaac Newton. So what would be the answer? You create a new balance of forces in the joint, in the musculoskeletal system of the patient. And a new set of biomechanical parameters is going to be there and work for the life of the patient. A new set of biomechanical parameters. And look, forces, they move our joints, but they can wear it too. They can make the joint stable, but they can make it unstable too. So knowing how it works is a paramount fundamental knowledge we must have. Look, this is the total knee arthroplasty failing reasons, main failure reasons. Tell me which one of these reasons are not related to gravity, forces, and so on. Which one is not related? Infection. Another one? No. Stiffness is a force. Is a reaction to force, because otherwise you won't be stiff. Just no one else than infection. So you see that there is a reason why we talk about that. Let's go a little bit into the topic. The chain, what I call the chain of wear. We have forces which brings to loads. Forces creates loads. Loads creates stresses. And stresses creates wear. Is this a problem? Yes, but is this strange? No, this is not strange. That's just life. It always happens. You cannot get rid of it. This chain is something that is absolutely normal anywhere at any time. But what about the chain of accelerated wear? You have uneven forces. Could we have the same as before? With the lights, backlight? Okay, thank you very much. I like to see people in the face. Uneven, unbalanced forces are the problem because they bring to peak loads, and the peak loads they bring to concentrated stresses, and concentrated stresses brings to accelerated wear. This is not life. I call this a mistake. And this is what we must, at all costs, avoid. And remember that wear can affect both the material of the prosthesis, but also the soft tissues. So let's dive deep into this. What are the forces on joints? We have passive forces, and this is what we said before, and we have gravity and ligament tension. That's why I said stiffness is about forces again. And we also have active forces done by muscles, activated by muscles. So what I call the Tao of joints, the objective is the equilibrium of passive forces, which equilibrium will allow for a well-balanced deployment of active forces. Fall on the ground. And so we can avoid peak loads, reduce stresses, minimize wear, and stabilize the joints. what are the possibility we have to affect this issue? During a surgery of total arthroplasty or arthroplasty, we have basically two ways: cut alignment and balancing, gap balancing of the ligaments. This is a picture. When I first saw it, I am an engineer, basically. So when I've seen that, I thought, oh, this reminds me something. What it is not, and of course, is an arch. Is an arch with this keystone, and the keystone carries the whole body weight. So the arch also have a center of gravity. And let's look at forces, how work in this case. So you have the weight applied to the keystone, which is the keystone. The keystone is, in this case, of course, it's the sacrum. So what happens when we walk? Just a very, very broad assessment. We go on, and this is the situation. We have a balanced weight between the two legs, the two columns of the arch. Then we go on. We go forward until something dramatic happens. What could be? What dramatic thing could happen? We raise the leg. And when we do that, the body weight go to one leg, the center of rotation displaces towards the standing leg, and then what happens when I'm like that? My body, because of Isaac Newton, tends to go like this. So the abductors have to react to that. But this is not all, because when I go on, I have a kinetic, a massing kinetic movement. So I tend to do like that, because this is a hinge. So extra rotators, and especially the biceps femoris, will have to counteract this action. And also, I tend to do like that. So we will have the rectus femoris reacting to that, etc. I think that anyone here could cover all these kind of different effects better than me. So after that, we finally put our second leg. For the third one, we have to wait some millions of years. On the floor, and everything comes back to, let's say, a balanced position. So what I want to say with that all those reactions creates a stress on the acetabulum. And these stresses can be as high as this, 3-4 times, even more, the body weight on the acetabulum. So here comes the importance of mechanical parameters. A short review of hip parameters, which are somehow simpler than for the knee. Here you have the center of rotation, of course, doesn't need any explanation. But the center of rotation is determined, is made usually by reaming the acetabulum. So while you ream the acetabulum, you are setting the new center of rotation. I make an important question to you. Do you think that restoring the previous biomechanical situation is the goal of the surgery? This is not a trivial question. Because the question really is, do you think that the previous biomechanical, let's say, balance was good for the body? Was the best one? I tend, as an engineer, I tend to think that the previous balance, the previous situation, what could be what brought the patient on that OR. So I don't have a real answer. But I would say let's think before making sure that restoring the previous situation is always the best thing to do. Also because there are procedures, concepts that all brings to aim to restore the previous situation. We are talking about mechanics. So the body is an astonishing machine, but as anything is not perfect. So then you have the offset. The offset is the distance between the axis of the bone and the center of rotation. This is important, particularly important, because here you have the trochanter. The center of rotation is the lever arm of the abductor muscles. So, let's say in theory, the bigger it is, the less effort the abductor muscles will do. Of course, you cannot put the leg here, and you cannot stretch the muscles too much, but this could be a solution in case of laxity, in case of instability, etc. More or less the same thing. The vertical drop, of course, is the length, affects the length of the leg, and also the stiffness of the tension of the ligaments, but does not affect the work of the abductor muscles. I go a little bit fast here because the funny things comes with the lower part of the legs. Of course, you have, let's say, different effects of different situations of these biomechanical parameters. Each one brings pros and contras when you deal with it. I think you will have this presentation, so these are pretty trivial and obvious effects. We can skip that. Also, antiversion has an effect. Is the angle, there is a bit of confusion here. The antiversion is the angle between the knee epicondylar axis and the axis of the neck. But anyway, I don't want to stick too much on that. So here we see that an incorrect balance may result in uneven stresses and even over the neighboring and contralateral structures. If you have a problem here, then you will stress the other leg, for instance. But again, let's go on. So we come to our arch. and we go a little bit lower. We go to the knee. Here there is one parameter which is very important and that Professor Stavrev already underlined and highlighted very, very correctly, which is the biomechanical axis. The biomechanical axis is the line joining the point of application of the body weight, which is the center of rotation of the hip, and the reaction of the floor. The reaction of the floor applies on the talus of the foot, and goes straight regardless the position of the bone. Goes straight regardless the position of the bone. This brings several effects. Then you have the center of the knee, which is another important point. So, if, I hope you can see here, the WR line, the mechanical axis, runs through the point C, and the contact surfaces are 90 degrees with the mechanical axis, then you have pure compressive forces. Meaning that you achieve the lowest contact stresses and then the lowest wear. Can you remember the slide with the chain of wear? Is this? Do you have any problem with this slide? Is intuitively clear? So, also in knee, we have important forces going on. Several times the body weight. But things could go even worse than that, because if the mechanical axis is not passing through the center of rotation of the knee, what happens? In this case, varus, valgus, straight but sloped. In this case, you have overturning forces. The first thing that happens is that, more or less, you lose the contact on the other side. And this means that the whole body weight is in one side, in one condyle. In this case, you create shear forces, which tends to dislocate. It normally doesn't happen, but this creates unbalancing of forces. Or valgus, you have the same problem as the varus, by the other side. Patella, again, it's all about forces and even more dramatic than before. You have the force quadrilateral, which is usual for classic physics, that you have the quadriceps force, which is Q, the constraint force, which is given by the subpatellar tendon, Thank you very much, and the reaction force. The reaction force is always perpendicular to the patella. So the smaller is this angle, the bigger is the reaction force. So meaning that when you are in extension, there is practically no force, and when you are in flexion, you have the maximum load, and there is another factor, because this is in the sagittal plane, but in the frontal plane you have again such a thing, a quadrilateral of forces, which is lead by the Q angle. The Q angle, I think that the meaning of these two lines is very obvious. This is the insertion of the subpatellar tendon. So this creates the Q angle, and the bigger is the, I'm sorry, I turn it off everything here. Okay. The bigger the Q angle is, the bigger the force that tends to dislocate the patella in the lateral direction. And here comes a problem, because the first thing you do when you make a joint knee replacement is to cut the medial parapatellar ligament. And this is something that you have to take into account. So increasing the Q angle is never a good idea. So you can use several, let's say, tricks to decrease it, like working on the alignment, or maybe displacing a little bit the patella, let's say the prosthesis laterally. But increasing it is never a great idea. And this is also another one of the reasons why you, for important valguses, you might think using the lateral approach instead of the medial parapatellar, in order to preserve the medial structures intact and working. So, balance of forces. You have, as we said, the reaction of, the action of the vastus intermedius and the rectus femoris, which is counteracted by the patellar tendon. You have let's say the force, the result of forces toward the lateral direction, which is counteracted by the medial parapatellar, medial patellofemoral ligament. You have vastus lateralis and medial retinaculum. You have vastus medialis and lateral retinaculum. So here you have a plastic demonstration of the balance of forces I was talking about before. It is important to preserve it. I come a little bit deeper into a knee surgery. And you can see that usually you want to use the posterior condyle line. I'm not a big fan of it, because if the guy is there on that OR, means that there is a problem there. So if you take it as your only reference for the rotation of the implant, what is the rotation of the implant? It's basically what determines the patellar track. The track of the patella is determined by the rotation of the component. So the posterior condyle, are not a great deal for rotation. Also, the transepicondylar axis is difficult to palpation to locate. The trochlear axis, the famous wide side line, is there for you. And it is our goal. The goal of trying to determine the interaxial rotation is that. And it's there, you can see it. So you track it and go on. So usually you want to use all of the different references while trying to determine the intra-extra rotation. Look, this is pretty impressive. This is the same breakdown of forces on patella. And someone like me, 83 kilograms, can develop a force as high as 1,720 kilograms on the patella. This just to stress the importance of the patella tracking on prosthesis. Effect on malrotation, you have tons of papers stating this thing. So what I have to understand when I use one instrumentation is, does my instrumentation allows me to do all that precisely, safely, consistently? To which extent should I adapt myself and the patient to the limitation of the instruments? That is, I am following the characteristics of the patient, or I am modifying the characteristic of the patient to follow the limitation of my instrumentation or of, let's say, my procedure. This is an important question. There are a lot of interesting things to say about it, but it would need one day, one full day. Also, just mention to an issue that is, you will hear about it over and over and over and over with no solution. Gap balancing or measured resection. That is, I base my action on the surgery from the measure of resections or from the balancing of ligaments. Of course, no one actually does one or the other. When you go to the OR in all of the parts of the world, as I had to do, you see that this question is trivial, has no sense. Each and every surgeon does both at the same time. Maybe this will make sense, more sense with the experience on this. And another stuff, the gap balancing, guys, is so easy with the tensioner, with the ligament tensor. You put it there, 11 Newton, go on, great. Do you think that these two people have the same ligament tension? One is most famous Shaquille O'Neal, basket player, with a knee that is big like my head. And the other one is a little grandma, you know, fragile and everything. So also the activities they do are pretty different. I mean, grandma, maybe she was a great basket player also, but at this stage, maybe she's not. So is it right to give them the same ligament tension? So let me introduce you Mr. Thomas Young and Mr. Robert Hooke, which you don't know, but they rule our lives. Calculations, okay? Calculations that says that if you put the same ligament tension to both, one is going to be lax and you are going to break the other one. So I finish here. I'm sorry for the length of my presentation. I apologize, but The general physics may sometimes turn a light on where clinical research may face lots of complicated cross effects or carry too many concurrent confounding factors. And so you really don't know how that single procedure, that single action gesture you do in OR is good or not. But balance is the key, and I think that the crew I enrolled for this presentation may shed a light on your action in and outside OR. Thank you very much.
Thanks, Dr. Simoncini. And the second presentation is named Artificial Intelligence and Advanced Machine Learning Modeling in Arthroplasty, presented by Monov from Plovdiv University.
Okay, hello, I'm Simeon Monov, I'm from Plovdiv University. I'll talk a little bit different topic, related, of course, to arthroplasty. Sorry for my terminology sometimes, but what is artificial intelligence? Artificial intelligence, so popular nowadays. Everybody talks about it. It is the ability of machines to perform tasks that are commonly associated with human or intelligent beings. Things like reasoning, discovering meanings, generalizing things, and also learn from experience, like we humans do. And also, in this big field of the science, there's been a lot of research going on, and for the last 2 decades, it's quite hot topic, and especially in orthopedics and all the medicine fields. Now, okay, a small slide about technologies, what exists in artificial, because we say artificial intelligence, it's a science. Most of my talks are related on research. Some are used in like 3D modeling and other things are currently used. Many things are still research, but there is a lot of future here. Now, AI technologies, machine learning, everybody heard of it. That's the field, it's a field of the artificial intelligence science that focuses on algorithms that can learn from data and big amounts of data, but they do learn similar to humans do. They gradually learn these algorithms and they improve their accuracy. Everybody heard about the artificial neural networks. These are models. They are statistical models that they can perform different things. They are inspired by the human brain. That's why they are called neural networks. Again, they are inspired. Their core is built on the neural networks that we know about the human, but they do diverge in their own way nowadays. They're mathematical models, but yes, they mimic our brain or the neural networks in the, not only the humans, but in general. Now, interesting field that is used very much in, is this the pointer? Okay, one of the technologies used a lot in medicine or arthroplasty is the computer vision. Computer vision is just, again, a field of AI or that can extract meaningful information from images, videos, and different media, visual inputs. And the last is the natural language processing. Nowadays it become very popular, especially recently, this year. There is a big hype about it. It's understanding language. It's important. I mean, we have diagnoses, we have different documents that can be associated with images and other things, and all this we can make a good picture for predictions, different predictions. Now, applications in orthopedics, that's what I will talk about. Now, image recognition diagnostics, different applications, for example, highlighting implant malpositions, detecting features of loosening of the implants just by providing radiographs or X-ray images is good enough. I'll show you there's some research done, and it's quite accurate, in fact. It's used for risk prediction, predictions, outcome predictions, rehabilitation procedures after surgeries. There is an interesting field of computer-aided surgeries, still in quite early stage, but it's very interesting and important, helping clinicians to make right decisions. And I'm saying helping, because these are tools that help the doctors. They don't replace. And there is a big misunderstanding about AI that it will replace us. That's not true, at least not for now, and not in the near future. And interesting, in fact, real applications is automatic bone segmentation just from CT scans or MRI pictures, and creating 3D models totally automatically, which can help for implant selections and other applications. About image recognition diagnostics, no, I said it's a helping tool, but there is quite research done here. This is maybe the biggest field that is working on. Convolutional neural networks, these are special neural networks models that are very capable of detecting things on pictures. They've been used for example, diagnosing progression of osteoarthritis, just based on knee radiographs. Also, there was some, in fact, quite a research about prosthetic loosening, and they came out with this 95.6% accuracy, which is quite impressive for just a machine to detect loosening by looking into radiographs of the knee. Now, another field, preoperative evaluation, important. I mean, it allows to predict this, again, these models or neural networks. They are quite capable of predicting things. Of course, we need to teach them. That's the big issue, and I have a nice slide at the end talking about the problems there. Yeah, if they are trained quite well, they can predict quite well. And yeah, one of the applications is identifying high-risk patients. For example, another thing is in the revision arthroplasty, where the models being shown to identify, in fact, the implant manufacturers and also the design, which I believe can help a lot the surgeons ahead of time to know what's inside. And there is a quite good accuracy here as well, about 99% accuracy to detect or identify just by looking into radiographs. Another field, outcome prediction. That's also interesting thing. They can kind of predict the outcome before even the surgery, and this is important to just share and meet the patient's expectations, of course. They can, again, give, it's a good tool to give the doctors, of course. Here is a lot of involvement as well, right? I mean, there is psychology, there is many things, but these models are quite objective, and they can give information to the doctors ahead of time, which I believe it's a good thing. Now, in the post-operative evaluation and monitoring, of course, ML, machine learning technologies, they help in rehabilitation because they can, in fact, connect with wearable devices that provide a lot of data, detect certain what can happen. There have been some algorithms that have been researched and tested that they can in fact accurately predict the chance of fall. And this can help, working with the patients and avoiding these situations, of course. Now, the field of computer-aided surgery, it's still new. I mean, there has been work done here a lot. Of course, robotic-assisted surgeries, they help, can help the surgeon. AI can improve a lot of things like decision-making, predictions, quite precisely, and give safety and efficiency, of course. There were some AI models that have been tested that can do a guided surgery just by 3D reconstruction from a CT data of a lower limbs. In fact, the model construction itself took just 4.7 minutes. It was able to create a full 3D model just from the CAT scan data. Now, another field which, in fact, this is in application, there are certain companies who make implants. They can do a 3D model generation again just out of CT scans or MRI scans or X-rays. They can detect the bones, create models after that. This is in real production. It's being used for better implant selection for the manufacturers. Now, the last thing, clinical decision making, again, emphasizing on this, don't rely on AI, but use it as a tool. I mean, it won't replace us. Again, these systems, they do very objective predictions. They can help a lot. Now, they have the ability to really process huge amounts of data and then learn from them and can help and support doctors and patients from different points. I mean, another point is cost evaluations. There is many things. Any statistical fields, they are very good in this, and also image recognition, especially in this field. Now, the last slide is the longest, and this is important, limitations and challenges. The biggest limitation, a lot of data. We need a lot of data. And it's a problem. Not all clinics have a lot of data. And also, data is so different. What data means? I mean, it's related to population, especially how the previous presentation we saw, we have certain population can have certain structures. Of course, we need different data for the different population, and that's a challenge. It's difficult to find so much data. Recent algorithms that exist with the transformer models, we heard about ChatGPT and all this, they now learn by themselves. We don't need to supervise them. It's called unsupervised learning. Maybe there's a big potential there. But again, these models make mistakes. And very important, transparency and trust in AI algorithms. This is important because if we trust them, they will help. But we always need to have something in mind because, again, they are trained on algorithms. They may make mistakes. If we miss certain data, then that's a problem. And yeah, I was a little short. I hope this way I help with the time. But AI is great. I mean, it's being used. We don't have a choice. We will proceed with this. And it's important to learn how to use it to help us in any field, including, especially in medicine. It helps. Thank you.
Thank you, Dr. Mono. The next presentation, lower limb fractures with vascular injuries. Dr. Brunetto.
Dear colleagues, good morning. Thank you very much for the kind invitation. So we start to say a few words about the vascular injuries in the lower limb trauma. So we can identify the fractures and displacement. In open fractures, this places the fractures, dislocation or contusion, and the irreducible dislocation. And in trauma, complex trauma, unstable fracture, multiple injury the patient, compartment syndrome, and also amputation. As you see, this was a poor man who arrived in my hospital, unfortunately died, because when they called me from the helicopter, I said, please don't bring the patient to me because he will arrive, died, happened. Should be the best? To go to the first surgeon to close the artery and save the life. But unfortunately, there was nobody, and the poor man lost the life. So, in the bone extremities, we can have the involvement of the vessels. You can see a trauma of the knee, the lesion of the popliteal artery, and another trauma of the femur, the complete occlusion of the artery. Some other patterns of knee dislocation, you probably know dislocation of the knee much better than me. We can see the popliteal artery involvement in the dislocation of the knee. So, what are the general principles to approach this kind of patient? As always, be sure of a stable cardiac activity, make sure of the airways, put a large intravenous, this was the timer. External compression to control the bleeding, and look for signs of arterial lesions. The clock starts ticking, so the losing of blood is very important. We can have a compressive ischemia, we can have a tisutal necrosis, and a compartment syndrome. But remember, irreversible damage starts after about 6 hours of ischemia. I would like to underline this sentence, especially to the youngers, because most of vascular injuries in the trauma, unfortunately, are recognized late, because at first, normally in trauma center, the main important is to the general condition or the bone fractures. Why suspected vascular injury? Because of the external bleeding, the expanding hematoma with shock, or a limb ischemia. And the question is, blunt or penetrating injury, arterial or venous injury? Send the patient directly to the OR, and also what is the first thing we have to do, and which are the main investigation we have to perform before the operation. First question, is venous or arterial injury? Dark blood external bleeding at a low pressure is for venous injury, non-expanding hematoma. Shock is rare unless associated with arterial injuries. For the arterial injuries, the pulsating external bleeding, the absence of pulsation. I would like once again to underline that to look for the pulses is the first thing to do when you approach a multi-trauma patient. The expanding hematoma, or the distal ischemia, or the presence of a trill or bruit in several anatomic regions. So we can find vascular injuries in the femoral trauma, or in the popliteal, in the knee trauma, or in tibial trauma. So you can find in the lower limb mostly an involvement of the femoral artery, the popliteal artery, and tibial arteries. Types of vascular injuries after trauma. The spasm is the lowest kind of trauma for the vessel. The subintimal hematoma, the intimal rupture, the intimal flap that can lead to a dissection, the laceration transection, or the thrombosis. The blood loss, the ischemia, the compartment syndrome you know very well, the tissue necrosis, or the amputation, or the exodus of the patient. Between 25 and 75 of popliteal injuries are due to a blunt trauma. The evidence of ongoing bleeding, the limb ischemia, the expanding hematoma, the pseudoaneurysm you can see in this image is very, very interesting. It's not easy to understand immediately. And the nerve compression. So these are a few images of the type of vascular wall lesion. And please note that if you have not critical artery or localized injury, you can treat by endovascular treatment. You have to send the patient to endovascular surgery or interventional radiology for a stenting or an embolizing treatment, or a surgical reconstruction, or if it's necessary, directly to amputation. Remember that sometimes the amputation probably is very hard decision, but is the best decision for the life of the patient. So let me show you something about the knee dislocation. And this is a very interesting mechanism. I would like to underline the subadventitial rupture. This is the knee dislocation. You have the trauma from the extremity of the bone to the arterial wall. And you have the rupture of the intima and not the adventitia, because they are different in their elasticity. So the intima very easily will go to a rupture, and the thrombus mechanism will start slowly, and after a few hours you can find a complete thrombosis. Please remember this mechanism because it's very, very dangerous. And the complete condition of the patient, of the leg, you will see a few hours later. This is an angiography. This is the Doppler curve above the lesion, and this is below the lesion. You see, just before the angiography, only a duplex ultrasound exam is enough to understand that something should be in this artery. And this is the endovascular treatment with a covered stent. This is a very interesting case, a male, 37 years old, after unicompartmental osteoarthritis in valgus right knee, the implantation of a pudus plate for open wedge tibial osteotomy. Look at the compression of the artery. This is the angiography 6 hours after the implantation. This is another case, very interesting. Left femoral head dysplasia with a severe osteoarthritis. The patient was treated. and after few days, the patient arrived me from another hospital 6 days after because of a bleeding, a losing of a reducing of hemoglobin, and we could find through the CT scan the bleeding, the hematoma, and we ligated the first collateral of a perforating branch of the profunda femoris. Which kind of repair we can do if we have a damaged artery? Or one tension-free primary repair, or we can use a vein patch or a prosthetic patch, or one venous graft interposition. And if you need more time, we have to use one temporary shunt to let the leg to be perfused by the blood. This is one expanding hematoma. This is the CT scan. You see the fracture and the involvement of the artery. This is one subadvential rupture that I showed you before. This is the medial condylus. This is the artery. This is the aspect of the artery. There's no bleeding, of course, but the intima is ruptured and there is a thrombosis. So we did one venous interposition. This is the result. This is one fracture of the elbow, not the lower limb, sorry. But it's interesting because of the use of a temporary shunt. This is a very interesting case, a terrible fracture with the vessel involvement. We make a reconstruction of the posterior tibial artery and the anterior too. And this was the result the day after. Let me show you another case, very interesting. You see the girl, the young girl, was reached by a gunshot. You see the bullet here. Here is the femoral fracture and one huge hematoma. This is the external fixation by our orthopedics. You see the bullet here. This is the intraoperative view with a complete lesion of the artery and of the vein, both vessels. This is the result after reconstruction. This terrible noise was the Doppler sign. And we make a reconstruction of the artery, see, and also of the vein. Because sometimes to reconstruct the vein is very, very important. Also we can, if we can ligate, of course. And go to the conclusion. Keep in mind, evaluate the arterial wall, evaluate inflow and outflow. Be prepared to do on-table angiography. Always establish a good exposure. Remember that sometimes mini-invasive maxi problem. Establish the proximal then distal arterial control. Use temporary shunt if you need more time. Use local and general heparin. Don't be afraid to use heparin because sometimes thrombosis is worse than bleeding. Make your arterial repair tension-free. Prefer autogenous vein graft than prosthesis for microbiological reason, of course, for the risk of infection, of course. And almost all veins can be ligated when necessary, but if you can make a reconstruction, if the patient is stable, do also a venous reconstruction. Surgical consideration. Who goes first? Discuss with the vascular surgeon and the trauma orthopedic surgeon. Temporary shunt sometimes is interesting. Fracture stabilization normally is the first maneuver to perform. Salvage versus amputation, think about the gravity of the trauma. And fasciotomy is for prophylactic after ischemia against a compartment syndrome. And in conclusion, time is crucial. Be suspicious for critical signs. Early diagnostic Doppler or CT scan are more than enough. Have defined the protocol relationship between vascular and trauma surgeons. Be prepared for vascular repair. Timing is important. Bone stabilization first, vascular reconstructions, nerves, soft tissue. Thank you for your attention.
Thank you, Dr. Brunetto. And the next presentation, Surgical Strategies in Proximal Femur Fracture by Fanga.
Good morning, thank you. I want to thank all the people involved in organizing this course and for the kind invitation. I'm Dr. Fanga, someone know me, and from the University of Messina. In our trauma center, we treat many proximal femur fractures that we know are a social problem because the proximal femur fractures are frequently in the elderly, and their number is increasing, estimating over 7 million fractures in 2050. This is tightly related to the population aging, and at the same time we are facing with patients with high functional necessities. From a functional point of view, the proximal femur shows compressive and tensile trabeculae that characteristically from the word triangle as a zone of low trabecular density. With age, the trabecular structure degenerates, and concomitantly reinforcements like the calcar femoral lose structural integrity. Thus, a correct reduction of the calcar femoral is a key factor in the operative treatment of proximal femoral fractures. They are usually divided into intracapsular and tracapsular femoral neck fractures, including intertrochanteric and subtrochanteric fractures. Depending on their locations, femoral neck fractures are identified as subcapital, mid-cervical, and basicervical fractures. Especially in the elderly, the mid-cervical femoral fracture is the most common by far, with the frequency of over 86%. Let's start from femoral head fracture. Fortunately, are very rare. Usually are secondary at high energy traumas and followed by hip dislocation. The most widely used classification is Pipkins, which divides them into 4 types, depending on the involvement of the neck or acetabulum. In these cases, the treatment is usually conservative, but with the CRIF or ORIF techniques, but in some cases, prosthetic replacement may be necessary, for example, in the elderly patients. Femoral neck fractures, as we say before, are very common, especially in female patients. Here you can see the risk factors, wide race, increasing age, tobacco and alcohol use, a previous factor maybe. They are usually secondary to low energy traumas in older patients or following high energy traumas in younger ones, or maybe after cyclical loadings. The most commonly used classification are Powell's and Gardner's ones, are functional classification. And the goals of treatment vary from the young patient to the elderly one. In the young patient, we always need to try to save, if possible, the femoral head, and avoid the necrosis whenever it's possible. On the other hand, in the elderly patients, we need to regain loads and be able to walk at an early stage. in an early attempt to save the femoral head, we try always to perform a gentle reductive maneuvers for the reduction if the fracture is not well reduced. And then, if possible, we perform the synthesis. We usually the well-known Whitman technique and the Leadbetter technique if it's not useful, unsuccessful. Relating to biomechanical aspect, according to Powell classification, any femoral neck fractures classified as type 1 or 2 is an indication for internal fixation with cannulated screw, positioned in this way. Because of the blood supply of the femoral head, femoral neck fractures that are classified as Gardner 3 and 4 are often not suitable for osteosynthesis. So dislocated femoral neck fractures are related to high incidence of interrupted blood supply. And we can see the result in this X-ray. So for this reason, there is a higher possibility of fixation failure. And in these cases, we need to perform a total lip arthroplasty. Let's talk about the intertrochanteric fractures. They are the most frequent fractures we see in the PS. From a functional point of view, I don't know why this slide is rotated. The most commonly used classification is the Evans one, which classifies them into stable and unstable fractures. It's very useful. From an educational point of view, the most widely used is the EO one. For intertrochanteric and subtrochanteric fractures, the treatment of choice we know always it's the intramedullary nail because it reduces some soft tissue damage and allows early wet bearing. In some cases, when you evaluated for a synthesis of intertrochanteric fractures, you need always to see the stability of the fracture pattern defined by the lateral cortical wall. In some cases, rare cases, when the lateral cortical wall is intact, you can choose for an extramedullary device, maybe. But the cephalomedullary nail have some good advantages, like a maintainment of anatomical axis rotation and length with no fracture exposure. So we almost always choose this kind of implant. Now I show you a short video that illustrating the surgical technique of placing a gamma long, in this case intramedullary nailing. It's a didactic video for the students, so you can see. After we position the patient with the lower limb to the bed in example traction, we reduce the fracture and you can see the instrumentary. Then we need to identify the apex of the greater trochanter and make an incision just 2-3 centimeters above the apex, as you can see in video. The first time you perform this kind of surgery, it's useful to use the X-rays to see the apex of the trochanter. And this is the incision. Okay. Then we dissect the skin, subcutaneous tissue, and fascia, and introduce the pointer. You can see that in this case, the pointer was also used for further reduce the fracture. After that, we can place the guide wire and within the bone canal if it's necessary. Usually for the gamma-free nail, it's necessary because of the diameter of the nail. This was a long nail, so you need to choose the size of the nail. When the size was chosen, you can perform the implantation. One trick is to not hammer it because you can displace the fracture. Then we can proceed to the placement of the cephalic screw endoscopic control. This is a rotation screw, but there are other nail like TFNA when you can use a blade. Maybe you can choose between this kind of screw basing on the pattern of the fracture. In this case, then you need to blocking distally the nail with a guide. And here are some tricks to avoid implant complication, implant failure, such as screw out, and these are the TAD and CalTAD calculation. The tip to apex distance, called the TAD, is the sum of the distance from the tip of the screw to the apex of the femoral head on LP and lateral radiographical projections. We recommend usually that the aim should be a TAD of under 25 millimeters. We authors. And the CalTAD is a new reference that we take from Calcar to TAD, always in EP and lateral views. Nowadays, the optimal CalTAD value has not yet been defined, but authors suggest to avoid the CalTAD over 35 millimeters. Another important concept is the positioning of the screw apex in the posterior inferior areas of the femoral head. That can lead to fewer complications. But some authors reported that positioning the screw in the lower quadrant may cause rotation of the femoral head. This complication may be, can be possible in rotational wires and only in the determinate pattern of fractures. But what you need always to keep in mind that the only way to reduce the complications is to perform a perfect reduction in AP and LL view. Like you can see. Sometimes you can reach it with some additional tricks. We usually put an Oman retractor in the incision for the position before the positioning of the screw. Not scream, but in some cases can be useful deciding to perform primarily a total hip arthroplasty, especially when we have an arthritis, but literature is still controversial in this regard. So a few concepts to explain you something that you can take to home. Proximal femoral fracture have a strong social impact and they lead to loss of self-sufficiency and are frequent cause of mortality. Usually we obtain a good healing after correct treatment, but inferior results if the treatment is delayed beyond 58 hours. The correct choice of synthesis is essential. And good reduction is the key to good healing and avoid complication. If possible, avoid always to open the fracture, the focal edge of fracture, using cerclages, and always block, preferring a static block. An incorrect surgical technique is the main cause of implant failure. And endomedullary nading, as we saw, is the gold standard for fractures of the proximal femur in the trochanteric region. Thank you.
Thank you to Dr. Fanga. I have to invite Professor Vitiello for biopsy in bone and soft tissue tumor, the golden rules. Please.
Thank you. So, a biopsy in the bone and soft tissue tumor. First of all, what is a biopsy? It's a sampling of the tissue that we perform to make an histological or cytological examination to have a diagnosis. But when we have to perform a biopsy in the soft tissue lump? When this lump have a rapid growing, is painful, or if it's bigger than a golf ball. But it's very important also to make and appreciate the texture of the lump. And if this is very wooden, this is a very risk factor for a sarcoma So in all these cases, we have needing of performing a biopsy. But what kind of biopsy? There are two big family of biopsy. This is the incisional biopsy and the excisional biopsy. In the incisional biopsy, we have the closed one and the open biopsy. In the closed biopsy, we have the fine needle aspiration that is very common in other structure like the thyroid gland, but is quite uncommon in the soft tissue sarcoma, because when we perform this aspiration, we lost the spatial relationship between the cells. So there is a very high risk of false negative histological exam. And moreover, there is also a poor tissue sampling, so the histological and the pathological examination is very scarce. We can perform fine needle aspiration with ultrasound or better with the CT scan, but we have to avoid this type of examination. More useful is the core needle biopsy when we use a Yamshidi needle. This is on the upper part of the slide, and that allows us to take a carrot of the tissue that preserve the architecture of the cellular bone and make the pathologist to perform some immunochemical study that is very useful for reach a correct diagnosis. But there is also the risk that we haven't enough tissue for the diagnosis. So when we have complex cases or when we think that there is a malignant tumor and we can waste time for the diagnosis, we need an open biopsy. We also can mix the incisional technique, so we make a little incision, so an open biopsy, and then we perform a core needle biopsy. But the important is to take enough tissue to have a diagnosis. And what kind of incision? We have always to prefer longitudinal way. There is some particularity, such as the symphysis or the clavicular bone, where we can do an horizontal incision, but in the other case is always longitudinal, because in the second surgery we have the problem of contamination, so we have to have an excision of the previous scar, and when we have a longitudinal incision, the tissue that we have to take over is more and more, so there is some difficulty of reconstruction. We have to perform the smaller incision during incisional biopsy, centered on the lesion and far away as possible from the neurovascular bundle. And another important thing is that the surgeon that performed the incisional biopsy must to be the same of the subsequent surgery, because we have to plan before the surgery of the biopsy also the next step of surgery. And as I said, this is the second excisional biopsy when we have to take over the previous scar. So, what are the golden rule in the biopsy? First of all, no rush is not a game. We have to plan the type of biopsy and the next step before the biopsy. So we have to take our time during the biopsy, and we have to take our time in the surgery room. If we have some trouble or difficulty, we have to ask for the radiology in the operating room to make more projection. So no rush, first of all. Second, we have to not contaminate the vessel, nerve, and joints. The vessel and nerves cross different anatomical compartments during their way. So if we, during the incisional biopsy, we contaminate one vessel, during the second surgery, we have to take into account that all the vessel was contaminated by the tumor. So the second step of surgery have to be more and more aggressive. We have to take over all the compartment that was taken by the cancer. The same is for the joints. This is why we avoid the arthroscopic biopsy, because if there is a lesion of the proximal tibia and we perform a biopsy with an arthroscopical help, there is the high risk that we could contaminate all the joints with the cancer. And so the next step would be an extra-articular resection, so a more aggressive kind of surgery. In the operating room, we need the all preoperative imaging, an MRI, but also a C-arm, or the future is a biopsy guided by an O-arm in the operating theater. And we need a pathologist with experience in the musculoskeletal pathology. You have to know that more or less 1% of the all cancer in the adult is a sarcoma. But inside this little part of a primary tumor, there is over 200 types of cancer. So there is a very, very heterogeneous kind of cancer. And we need to have a pathologist that know to distinguish different types of cancer, because they have a completely different treatment. Some cancer, soft tissue cancer, need a neoadjuvant chemotherapy, other radiation therapy, or other need only surgery. And here in the table that I'm covering, there is a study that put in a difference between a center when there is a experienced pathology and another center in the without it. And there is 3 more time of error. So the pathologists make a role central in this kind of diagnosis. Then we have to choose the right way to perform an incisional biopsy. We have to take the shorter way. We have to center our incision on the lesion, and we have to avoid to contaminate different compartments. So we have to avoid to open different anatomical compartments, and if it's possible, we have to go throughout the different compartments in the septum behind the muscle, for example, because this is a very important, very important things to make in our mind for the next surgery. We have to plan the next surgery before the biopsy, and this is quite important because the same surgeon have to plan the biopsy. The biopsy is not a simple exam that we can leave to an expert in an experienced hand. We have to plan it in our mind, the first step and the next step. Then we have to take enough tissue. We don't have scary to take more and more tissue. In the past year, the pathologists make a simple exam, but nowadays he performs immunohistochemical analysis. The future is the spatial analysis, the proteomics. So the pathologists need a lot of tissue to perform all our analysis. That is very important for the oncologist, because there is a prognostic factor or candidate the patient to a biological therapy. And there is another issue very important to take enough tissue. Here you can see an image that is a fibroma. The red part is the previous biopsy, but you can see that in the lateral part of this lesion there is a different population. This is quite common in the soft tissue sarcoma, that inside the same tumor there is different type of population of cancer. So the white one is a fibroma, but the other is a fibrosarcoma. And the pathologist, with the only first biopsy, give a diagnosis of a benign tumor. But this is a G3 fibrosarcoma, so a malignant tumor that need completely different treatment. So take a lot of tissue. And last of all, we have to be atraumatic, because we have to avoid the hematoma. The hematoma could grow inside the different compartment of the limb, and so make a contamination of different compartment. And so we have to take in account in the next surgery that there is a contamination of all the leg, like this photo, in which the hematoma have contaminated also the hip. So we have to perform an extra-articular hemipelvectomy. And so to avoid an hematoma, when we think that it will be an hematoma, we have to use a drain. But also when you use a drain, we have to take in our mind that the exit of the drain is also contaminated. So also the exit point of the drain is very important because we have to excision also the exit of the drain in the next surgery. So in the oncological surgery, the exit of the drain is always in line with the incision nearest as possible, because in the next step of surgery we have to have the excision of the scar tissue and the exit of the drain. This is a practical example of what I've already said. Is a study in when there is 24 residents. The half have an experience of 6 months in an oncological unit, the other only an experience in trauma surgery. All the residents that perform a period in the oncological units doesn't get a wrong incision during the biopsy. In the other case, in the 14% of the cases, there is a mistake. And of these 5 errors that you can see, in 3 cases was performed a major amputation that could be avoided with the right incision. So the biopsy represents the last step of the diagnostic process, but is the first step of the surgical treatment, and this have to be made by an expert of these cases because it's the first step of a long way. Thank you.
Thank you to Dr. Vitello for this interesting presentation. And now, Professor Timonov, bone fracture in child abuse syndrome.
Okay. My presentation is a little different from today's topic, long bone fractures in child abuse syndrome. My specialization, medical specialization, is forensic pathology, away from traumatology normally. First of all, I feel stressed when you see the living people in front of me. Today I want to underline the importance of the bone fractures, which can help you to identify the child abuse syndrome. Then I will present a real medical legal scenario from my practice to see this medical legal importance as the basic point for the child abuse, for the positive identification of the child abuse syndrome. What it means, the basic term, this is the no accidental injury in children. They can include a lot of injuries, like the fractures of the long bones, closed head injury, intra-abdominal injury, and so on, so on. But first of all, when you face a patient, child, with suspected diagnosis, child abuse syndrome, first of all, you have to think about his or her age, the history, the injury pattern, the mechanism of injury. All these points must be considered to put correct diagnosis of child abuse syndrome. On the scheme, you can see the basic points which can characterize this no accidental accident in children. First of all, this is atypical unexplained injuries, inconsistent history, social circumstances, mechanism inconsistent with the injury. You'll see the mismatch between the finding and the history for this type of the trauma. Delayed multiple presentation, multiple soft tissue bruising, subdural hematoma, bilateral retinal hemorrhages, and so on, so on. Therefore, these points play a role of the pieces in your puzzle. If you can put correctly into this puzzle, you can identify correctly this diagnosis. Red clinical signs from the bony pathology which play a role of these red flag signs, clinical signs. First of all, this is the posterior medial rib fracture, metaphyseal coronal fracture, or the bucket candle fractures, transverse fracture of the femur, sternal fracture, fracture of scapula, spinous process fracture. These types can help identify the child abuse syndrome. In USA, in England, when you think about the child abuse syndrome, when this diagnosis is expected, you have to report this case in the first 24 hours to specific agency. But on the other hand, you have to know that many bone pathology diseases can mimic the child abuse syndrome, like the copper deficiency, rickets, scurvy, hypervitaminosis A, connective tissue disorders. The most common example, this is the osteogenesis imperfecta, Coffee disease 2, osteomyelitis, metastatic tumors, birth trauma, and so on, so on. Therefore, first of all, you have to rule out these problems when you decide to put the diagnosis child abuse syndrome based on the bony findings, based on the fractures of the bone structures. Now, I want to recommend, this is the most common abuse red flag scorecard for the positive identification of the child abuse syndrome in the emergency departments in USA. This scheme, this card includes a lot of points related to the history findings, physical or imaging findings, and here I underlined the bony pathology which could be associated with the child abuse syndrome. First of all, this is the multiple fractures in the various stages of the healing. Flat bone fractures, I mentioned above, this is the sternal fracture, the scapular fracture, the vertebral fracture, the posterior rib fractures too, and on the last sentences, you can see the importance of the long bone fracture, femoral, tibia, humerus, metaphyseal corner, or bucket candle fractures. The last one, this is the gold standard for the child abuse syndrome. When you see this fracture, first of all, you have to think about the child abuse syndrome. The case report. 3-year-old female child was brought to the emergency room by her mother. She had sustained a fall 1 day ago and had fractured her left femur. During the X-ray examination, orthopedic surgical specialists find transverse fracture femoral shaft fracture. This is the key sign in the medical history. You have seen the mismatch between the falling and the production of this typical fracture in the child. The treatment is the normal application of the plastic cast. She was discharged from the hospital in a good condition, but 3 months, unfortunately 3 months after this situation, she was killed by her mother. The cause of death here, based on the forensic pathologist finding, this is the severe traumatic brain trauma. Huge subdural hematoma, plus the fractures of the facial bone. She was buried. During the exhumation, you can see the photos on the autopsy theater. Application of the plastic cast involved the leg limb. Here you can see the old transverse fracture of the femur. On the low, you can see the subdural hematoma and the fractures of the alveolar process of the maxilla. Typical blunt force trauma. Now, I want to point out the medical importance of the small piece into the huge puzzle, like the diagnosis. If this child was reported it, the final will be very, very different. Therefore, don't underestimate, don't overestimate the small pieces on the huge puzzle. Thanks for your attention.
Thank you very much to Professor Timonov for this very interesting presentation. So, please, if you have to...
Dear colleagues, the discussion will be after our greetings from the chorus of the university, Chor Veselje. So we'll listen their singing.
So we can conclude this section, and we start for the conclusion. I think we need a few minutes, if they are ready, for the Chor Veselje. Are they ready? In a few minutes. Okay.
So we're closing the session and we'll have lunch break.
Yes. Just a consideration. Now, the theoretical part of this course is at its end, but if you have any questions to do, please ask us. We shall be glad to answer. And your participation, I think that it is profitable. Thank you very much indeed.